Just thought
it's a lot worse than a dialysis machine. So usually for an adult patient, you are flowing anywhere between 3 to 5 liters of blood per minute. So you can imagine if a cannula comes out in 45 seconds, you've bled out half of your blood volume onto the back of the ambulance.
Hi everyone, this is the Para Podcast. It's us again, doing what we do, taking paramedicine from Africa to the world, and we're bringing the world to Africa. This time around, we're doing something a bit different. I'm sure you didn't expect this one, but we are excited to be talking about the topic that is going to be introduced by Martin shortly. Usual guests, people at the same time that you always have, Mr. Elias Thomas and Tulani Sibanda, who's currently on holiday. You can see he's looking fresh. And then we've got Martin Ellis, who is currently in Bloemfontein. How are you, Martin?
I'm okay. Just dying of heat in Bloemfontein, but other than that, no reason to complain.
Yeah, Bloemfontein has one of the important places in South Africa, being the heart of the Constitution. I always got fascinated about the way that Bloemfontein became a city, because there's just nothing there. It's just farming and people that just work hard and stuff like that. So it's a very different place. Just in the center, just while they decide Constitution is going to be there, and that's it. Yeah, but thanks for coming to the Para Podcast. We are going to talk about something that is close to your heart, and that is ECMO. Before we get to the ECMO bit, we've always had people talk about ECMO, but I think I would like to know your background first. We are a Para Podcast, and I believe you have a pre-hospital background. May you please tell us about that?
Yeah, sure. Thank you to all of you for having me on here. It's a real pleasure to be with you. So I did my ECP in Port Elizabeth, Gqeberha. I finished in 2022. I didn't really know what direction I was wanting to go in back when I finished. I just knew I wanted to get as much experience as I possibly could, which is why I went straight for wanting to work in Gauteng. So after graduating, I moved straight to Johannesburg, where I worked in private for a private service in Gauteng, on road ops. Got incredible experience, but not too long after working on the road and after getting a lot of good experience, I knew that my heart lay in critical care, and that's the direction that I wanted to go. So as soon as I possibly could, after I felt I was sort of starting to find my feet as a practitioner, I started to book overtime shifts and start doing training in the critical care division, specifically on the ICU ambulance at the beginning. So did all my training that was necessary at that point, started booking overtime shifts, started getting experience, and from that point in time just completely fell in love with critical care. And then not long after that, managed to get a full-time post in the critical care division, and worked full-time on the ICU ambulance. And that's sort of where I started getting my first taste of ECMO, and started being involved with ECMO training and ECMO retrievals that started happening on a more frequent basis. And somehow, things happened that most of the time they fell on my shift. And I was privileged enough to be able to be part of those retrievals and do those calls. And then from there on, I just spent a lot of time working in critical care, working on HEMS, still doing some road shifts in between, just to keep my hands dirty. But with my largest focus on critical care and critical care retrieval. And then from there, that's just where ECMO started taking the forefront of what I wanted to do and what I wanted to focus on, just with it being the pinnacle of critical care in general, and obviously the pinnacle of critical care retrieval.
Yeah, it's
And
quite
from
fascinating. Yeah,
yeah,
continue.
and then just moving on from that, after working quite a while in the critical care space and working within the ECMO space, I managed to get an opportunity to come and further my studies and study medicine in Bloemfontein, which is why I'm here now. So I'm now entering the second half of my second year of medicine in Bloemfontein, with the rest of all of my free time going into everything ECMO related, which we will get onto, I'm sure, at a later point. But yeah, that's pretty much my
Sounds
story.
very fascinating. Um, I think one thing that is interesting is that most people think that once you qualify as an ECP in the context of South Africa, you can just switch and you'll be in a critical care role and you just function optimally even there. But there's a big difference and a bit of a niche once you start working in the ICU ambulance specifically, and you just focus on it because there's a lot of stuff that goes on there. As you mentioning
Yes.
it is a critical care. I remember before I left South Africa, there was a lot of talks around introduction of ECMO in some of the ambulances. Some of my colleagues were talking about the trainings that they were attending. Others were stressed about it and stuff like that. So when was ECMO introduced to you?
So it was very early on, pretty much from when I moved into the critical care space, I knew of it. Obviously at university, I would say it was maybe spoken about for half an hour in my fourth year, just as something that I might see sometime in my career. Obviously
Yeah.
not knowing at all that it was going to be, reach the level that it has in my career, or, within my passions. So back then, not really knowing too much about it, just knowing that it did exist. But moving into the critical care space, I knew that it was something that the practitioners were doing, and that it was something that was becoming more and more regular. And it was sort of that thing that everyone spoke about, that, it's the hardest challenge. It's the pinnacle of what we do in critical care. And so that just made me want it even more, just getting that experience and getting that exposure. So it was quite early on. I think it was probably about 4 or 5 months into my full-time post on ICU, that I managed to have the opportunity to do my first ECMO transfer alone. Previously, I had made the effort to jump onto multiple different ECMO transfers, just assisting the ICU paramedic with those transfers, just to get the exposure, and just get used to the way things work. And then about 4 months into my time, I did my first one alone, and then it just grew from there.
Yeah. At the time when I worked in a GPG, Gauteng Provincial Government, I think we had about 8 ICU ambulance. They were good. They had a lot of equipment, but none of them had ECMO. I wonder if they have gone to introduce that maybe on one, or it's a bit far-fetched. Right. Now, I would like to dive into it now to colleagues that have never heard, because I also heard about ECMO when I was transferring to my BTech. That there was something called ECMO. Then soon after that, I had colleagues talking about it as people that are working in the ICU ambulance for other private ambulance services. Now, for a person who has who's worked in the ambulance, possibly in what was called the basic life support, never heard of this ECMO thing, how would you define ECMO? What is ECMO?
So I would. So first of all, obviously, just speaking about the word ECMO, obviously stands for extracorporeal membrane oxygenation, which means it's oxygenation of the blood outside of the body. So in critical care spaces or in ICU spaces, ECMO is the highest form of life support that we can have a patient on in an ICU setting. And it acts as a support for the heart and the lungs, either when the lungs are failing on their own, or when the heart is failing on its own, or if they have both failed. And it can have a function of supporting the lungs and doing the work of the lungs by oxygenating oxygenating the blood, removing of CO2, and then acting as a direct circulatory support for a failing heart. So it's the biggest thing that I would say to describe it is that it is a support. So think about a heart-lung machine that they would use in theater for a bypass. It's pretty much a mini bypass that you can keep a patient on for extended periods of time, that can give support to the heart and the lungs. But with the most important thing being that it is just a support, and not a treatment. So it's we refer to it as a bridge. So it's either a bridge to recovery, a bridge to decision, or a bridge to a plan of figuring out, what is going on with the patient, to determine the underlying cause. So, or it can be a bridge to transplant, which is not really used in South Africa, but is used very regularly for that purpose overseas.
All right. I used to teach basic life support. So I want us to take it slowly. I can hear what you're saying and I could clearly understand, but I want a person who doesn't understand this thing. They understand there's a heart over there and the heart has to circulate. The blood goes round and round and round in the body and the heart pumps it. And then oxygen is, the gases exchange happens in the lungs, where gases exchange happens and stuff like that. What you just said now, said ECMO, it's when oxygenation of the blood happens outside of the body.
Outside of the body. Yes.
That's fascinating, isn't it?
The easiest way for me to explain that is by sort of explaining the way that ECMO happens. I think that will give people a better idea of exactly what it does. So the way that ECMO works, it has a multitude of different components that make up the whole ECMO system. So first of all, it's obviously a fully closed system between the patient and the machine.
Sorry, explain what fully closed. What does that mean?
So it's a closed system it's the same way that a ventilator would work as a closed circuit between the ventilator and the patient's lungs. In you're not going to be exposed to, different forms of pathogens or whatever between the ventilator and the lungs, the same way the ECMO machine is a closed circuit between the patient's circulatory system and the machine. So it's pretty much an extension of the patient's circulatory system, of their blood vessel system. And you, as the person putting in the ECMO, are putting the patient on a support that is going to be happening outside of their body. So the system will work in such a way. You have a drainage cannula that is usually placed in a very large vein, either the jugular or the femoral vein, which is usually the first choice, and using a negative pressure centrifugal pump, which is what they call it, that sits in the machine. Blood is drawn out of the patient's venous system against a negative pressure. And it is drawn into a membrane oxygenator. So the membrane oxygenator is designed in such a way to mimic the lungs as best as possible. So it's a permeable membrane through which blood can flow very easily. It's sort of an interwoven mesh of different components that make it possible for the machine to, on one side, take out carbon dioxide, and on the other side, be able to add oxygen into the blood. So you are adding the membrane oxygenator is essentially acting as the patient's lungs until their own lungs have recovered to be able to take over that function. And then from there, the blood is then taken back into a return cannula, and using forward flow is pushed back into the patient's circulatory system, either back into their venous system if it is a patient who has only a lung issue, or it is placed back into their arterial system if it is a patient who has a combination of respiratory and cardiac failure. So I think the easiest way to sort of sum it up is that it's a situation where a patient's lungs or heart are not adequately functioning, despite optimal, conventional treatments. And it is a therapy where you are taking the blood out of the patient, you are removing CO2, you are adding oxygen, and you are adding a pump that is able to support the heart in its function of pumping blood around the body to deliver oxygen.
Amazing stuff. Amazing stuff. I have a lot of questions. I think Tulani has a question too. I can see him. He's salivating there. Yeah, go for it, Mr. Sibanda.
You made okay. So Martin, look, thanks for coming to the Para podcast. We've been battling to have someone on the Para podcast to come and talk on the ECMO, and I think it's quite an important thing that we talk about it because there is now a lot of growth of ECPs or paramedics worldwide utilizing ECMO. Obviously, not doing alone in conjunction with the physicians, the nurses. Yeah. And it's quite important that we educate people. Now, I think when you read about ECMO or in the general public, because this podcast is not just for us paramedics, it's also for the layman's people or the public, you know. If somebody had to say, what would you, in briefly, I know it's going to sound silly, but somebody might confuse an ECMO machine to a dialysis machine. And then I know you've spoken extensively about what an ECMO does, but how would you then slightly differentiate between an ECMO machine and a dialysis? Because in the general public, people, when they go to hospital, they'll see there's a big machine, it's a dialysis machine. And some of the ECMO machines that I've seen, they're quite big. But in briefly, how would the differentiation between an ECMO and a dialysis machine be?
So I think the biggest thing that we can use to differentiate that from a layman's perspective is obviously a large amount of the public would know what dialysis is for. Obviously, it's that big machine, and it's just there to support the kidneys. I think an easy way for people to remember it is, from a layman's perspective, people often speak about life support and turning off the machines when it's time for someone, when someone is coming to pass. And, that often involves turning off the ventilator or turning off the machines in general. And I think the biggest distinguisher there can be that, a dialysis machine is not a form of life support. It's just an adjunctive therapy. It's just a therapy that is used to treat the patient's condition or help treat it while you're treating the underlying cause of the kidney problem. Whereas the ECMO machine is physically there to keep the patient alive, the same way that a ventilator would keep the patient alive until you are able to sort out the problem. So I think it might be a little bit difficult to explain the difference for the people to be able to identify the difference between the machines. Obviously, because it's both have blood coming in and out of them. Both of them are big machines that are complicated. I can definitely say that a dialysis machine is a lot bigger than the ECMO machines we use now. ECMO machines have become very, very small. So I think if you see a massive machine with blood going through it in an ICU, you can be pretty sure that it's a dialysis machine and not an ECMO machine. But I think just from a mindset perspective, the shift would be that dialysis it would just be there to support the patient in one aspect of their kidneys, but not necessarily life support. Whereas an ECMO machine is supporting vital functions of the heart and the lungs to keep the patient alive until you can sort out the underlying condition.
Fascinating. Thanks. Fascinating stuff. This is pretty cool. So basically, they used to say that people used to say, so you're getting blood from it, so you're a vampire. I think the ECMO people are true vampires. Because you take a whole lot of blood. You put it somewhere else.
A lot.
There's this thing. Look, I've never seen an ECMO being in an environment where there was an ECMO process or procedure being done. But a lot of the medics that have done it first time around, and I'm sure you can attest to that, Martin, is that they'll say that the first thing is that this machine is horrible. The process, the cannulation is horrible because they put you can explain it better, but they put something to dilate the veins, and then blood squirts out, and they get shocked like, that's horrible. But as they get used to it, they say, no, then this procedure is quite good and beneficial for patients. I don't know. Like most of them, when I speak to them,
definitely.
like, the first time they say it's horrible. It's horrible seeing that. Having that experience.
Yeah, I think for a paramedic, especially when we do retrievals and stuff like that, we obviously there. Hands on and very up close and personal when they're physically doing the cannulation procedure, which as pre-hospital practitioners is not something we get to see very often. We don't get to see surgery being done on a regular basis. So it is definitely something to get used to at the beginning.
Yeah, because we paramedics, we normally talk about the 14 gauge is the biggest needle that we have. Now, in terms of the ECMO, what's the size of the needle that is put in the jugular vein or in the femoral vein that is used for ECMO?
So it can range. It will depend on the patient's size. So we talk about it in sizes of French. The same way we talk about urine catheters and NG tubes and stuff like that. It's spoken in those sizes. But the biggest sort of main aspect of it is that the drainage cannula is the big one, so it's large. It's very big.
In terms of the setup, because we understand that you are actually entering the patient's body now, which means there should be some form of sterility that is involved over there, like it should be clean. Yes. How do you maintain that in the ambulance? I've seen some of the jump bags that we have, and I don't think they are very clean. How do you ensure that? Do you do it at the back of the ambulance, or you want to do it in another control setting as compared to the ambulance?
No. So usually, if it is a retrieval that's being done, and the patient is being cannulated where they are at the referring facility. Then the cannulation is usually done in the ICU on the patient's ICU bed. So that's usually where it's done. So then it's a fully sterile surgical procedure that's done by the cannulating physician. And then obviously once the cannulation is done, everything is sutured closed, everything is dressed, and everything is closed up. And after that, it becomes like any normal patient that you then transport. There's not significant changes that happen when it comes to sterility during transport, because everything's already dressed up and closed and sutured and protected by the time you leave the ICU.
Mm. So, Martin, look. Oh, you want to go first, Elias?
Yeah, no, I just had a question because it's with regards to its application. I do know that the French are quite big on ECMO, and they're doing some of it in the pre-hospital setting as well, especially on cardiac arrest and traumatic arrests as well. And I know London Air Ambulance is also starting to do some on the streets. I'm picturing, South Africa being, I don't want to call it the capital of trauma, but there's quite a lot of gunshots that go on there. There's quite a lot of stabbings that go on there. And I think this will be beneficial. And I guess it's quite resource intensive in terms of the physicians that you need to apply it. I'm just wondering, like when intubation came in, it's only, it's highly trained doctors that could do it. But now, paramedics are doing it. Do you think this could be something that could be done by paramedics in the near future? Or perhaps if it is to be done, then what level of training would they require then, to apply it in the pre-hospital setting?
So I think definitely at the beginning, I definitely don't think from the start it would be something that can go into a pre-hospital practitioner's scope. If it is something that is applied, started in South Africa. It would probably be the experienced people from in hospital that would have to take a step to be able to do it outside of the hospital, and in that way the learning and the teaching will happen. So speaking about the French and the British that have started those programs of theirs, I was lucky enough to attend the Paris Rescue ECMO course last year, where the biggest focus was on doing pre-hospital ECPR, which is something they do on a regular basis in those areas, and is something that has recently started in London. But training is definitely, there. So I know that in New South Wales, in Australia, they have started a pre-hospital ECPR program, where they've actually done a whole process of training the pre-hospital critical care paramedics in ECMO. So at this stage, they're not the ones cannulating, but they are fully trained in understanding everything about ECMO to be able to be an assistant during those cases. So I'm not entirely sure. I don't think it's ever been done anywhere in the world yet where pre-hospital providers are the ones that are able to physically do the whole procedure on their own. I think it's, as a whole, the modality is very new, and I think everybody is still learning a lot together. And I think we're still quite a way away from that. I think you're first going to need to have the experienced physicians who are experienced cannulators coming out onto the road, doing it, teaching the paramedics, setting up dedicated training programs for pre-hospital staff to be fully trained in pre-hospital ECMO, that they can start gaining exposure. And then later on, there's ways to look at that. I think it would be very beneficial if that's a point we can get to in South Africa, just due to our resource constraints. And, we don't exactly have doctors to spare, to have doctors working permanently on the road, or, to have time to get them out of hospital to do it pre-hospitally. But I do think we're still, quite a way away from that.
Yeah, pretty cool. Now, from what you just explained now, I'm starting to believe that the cases that you did while you were working for the ICU ambulance was mainly transfers that you were doing. So did you participate in doing the whole setup of the ECMO in hospital? Where did you actually participate? Or what I'm trying to get at is, where are we in South Africa with the ECMO usage and as a pre-hospital industry?
There's the problem in South Africa that we're currently sitting with is the disparity. So there's a very, very big disparity of access to ECMO across the country, which is the biggest problem. So if you look at main areas, specifically Gauteng, I would definitely say that Gauteng is sort of the epicenter of ECMO in South Africa. There you have a lot of facilities that have ECMO capabilities. So if from a critical care retrieval perspective, working in Gauteng, the systems are set up in such a way that we were able to have a system in place where we could go out and do the retrievals. So I would say at least 80% of my cases that I did that involved ECMO was the whole entire process of going out with the team, doing the cannulation at the referring facility, packaging the patient, and then taking the patient back to the ECMO center. So it really depends. There's definitely very large parts of South Africa that don't have that kind of access or those kind of resources or that kind of expertise at the moment. And it's largely found in the big metropoles, with Gauteng sort of being the epicenter of it all. So I had a good mix in my experience of doing, fetching patients that are already on ECMO. Did a lot of cases where we are going to fetch a patient and taking them for ECMO, where you get to the receiving facility and they go on to ECMO straight away. You take them straight into theater, but I'd say a majority of my cases involving ECMO were going to do the whole process and putting them on ECMO at the referring facility.
Sounds good. And yes, Tulani.
Sorry there, Malusi. So I hope I'm not disturbing your train of thought, Malusi. Now, what I wanted to ask you, Martin, is that when you were transporting these cases or when you went to those facilities, is that obviously there's different types of ECMOs, do you mind sharing us about the different types of ECMOs that exist?
Do you mean specifically with the machines or just the different kind of cases?
With the machines specifically, because there's veno, there's arterial, and how it works, because there's ones that go to the lungs, and there's ones that include both the lungs, they support both the lungs and the heart.
And the heart.
That's what I was talking about.
Okay, yeah. So obviously, that decision is largely dependent on obviously what the patient's presentation is. So most of the time, a decision is already made before we leave what kind of ECMO the patient is going to be on. Most of the time, that doesn't change. Sometimes when we get there and the patient's condition is significantly different to what we thought, and we thought we were going to do only a lung support, a VV ECMO, and we get there and the patient is in full cardiorespiratory failure, and they require both lung and heart support, and we decide to put them on VA. Sometimes that would happen, but usually, especially in a system like Gauteng, where the referral system is very well set up, and there's a very good understanding of the ECMO system within the area, most of the time we would already have decided what kind of ECMO. So I think just to sort of explain that whole sort of dynamic of the different kinds of ECMO. So you get multiple different configurations of ECMO. So the two main ones are VV and VA ECMO. So VV being veno ECMO and VA being veno arterial ECMO. So those two different forms are just meaning that if it's VV, you are draining blood out of a vein and you're putting it back into a vein. And those cases are solely for respiratory and pulmonary support. And then for the VA side, you are draining out of a vein and you are returning retrograde back into an artery. And then that will be for cardio and respiratory support. With that, you do get a lot of different hybrid configurations. There are many to talk about. I'm not going to go into all of that, but you get different forms of different hybrid configurations that you can make use of for additional support in different areas. So you can get a VAV ECMOs where you have an additional drainage site, or you have a VVA, or you can have different where you have three cannulas involved, or you just have two drainage sites, or you have two return sites, depending on what kind of additional support the patient requires. But in the acute phases of an ECMO, it's usually either a VV or a VA, and those hybrid configurations come a lot later down, the process where decisions need to be made for if the patient requires additional support. So obviously the machines we use can do both VA, VV, whatever configuration you require. Every machine can do all of those configurations, so that doesn't really change anything for us. It's just what kind of support you then decide to give the patient, depending on whether you choose VV or VA ECMO. And then either way, you're supporting either the heart or the lungs, or just the lungs.
Yeah, this is really fascinating. Just listening to this is just incredible. I'm thinking now. I think we need to go and talk about what types of cases do we believe that ECMO is good for. We understand now that basically we're taking over the function of the lungs. So in this case, yeah, we're taking over the function of the lungs, and we're taking over the function of the oxygenation of blood. That's the core. This is what we're trying to do. So basically, there must be some organs that are functioning perfectly, so that we decide that these are the types of patients that we want to use this sort of tool to, in order to buy time before they get a definitive care. So now we're using this instrument, but now what I want us to get to is what types of patients do we say now this patient is going to get ECMO, and how do we select them? What's the criteria for selecting them while we're doing that? Or you can talk to that before I expand.
The selection criteria is a very contentious subject worldwide. Nobody can agree on it. So also does give guidelines, so that the international body for ECMO does give guidelines on, sort of selection criteria. But unfortunately, a lot of the selection criteria is largely based on the facility, what the facility is able to manage, the resources that are available. Obviously, the more resources you have, the lower your threshold can be to put a patient on ECMO. The less resources you have, the higher your threshold becomes. So it's really a very big balancing scale of, being able to choose the right patients. And that's also where sort of experience and really good training comes into place, and really good knowledge about what you are trying to achieve with the ECMO, and having a plan of what you are going to do once the patient is on ECMO. So there's multitude of different ways to approach it. But I think the main things that we can speak about when it comes to what patients can sort of benefit from this. So there's a lot of literature that talks about different levels of mortality, or different mortality rates. That, if the mortality rate is, say, between 50 or 80%, with optimal, ICU care, and they are still going to have a mortality rate of 50 to 80%, despite, every form of ICU intervention at its highest level. Then those are the kind of patients that would benefit from it. And then the specific subclasses of patients that we look at are specifically the sepsis ARDS patients that still have good neurological function and haven't had significant hypoxic brain injuries, the severe pneumonias, the cardiogenic shocks that are requiring increased amounts of inotropic support. So in other words, your refractory cardiogenic shocks. And then there's the scope of how ECMO can be utilized is growing as the research is growing. So there's a lot of different uses where it's now starting to be used for trauma-induced ARDS, where it can be used for different forms of overdoses, specifically your cardiac drug overdoses that cause severe cardiogenic shock. But I think you can focus on the main ones being, the refractory cardiogenic shock patients that still have good neurological function, and then your sepsis ARDS patients, and your septic pneumonia patients that still have some form of good neurological function that can still recover if you are able to fix the lungs. So I think the biggest talking point here is being able to decide whether the patient that's in front of you, if you are able to put them on ECMO and fix the biggest problem, whether that is the ARDS, or if it's the pneumonia, or if it's the overdose, or, the trauma-induced ARDS. The biggest question that is asked, especially in a South African setting, is, if I put this patient on ECMO and I'm able to fix the biggest problem and they can fully recover from that, will this patient be able to go back to being a fully, involved citizen of society? That's our biggest thing. So it doesn't help we're putting patients on ECMO and using this resource, and we send back a burden to families of patients that just end up being bedridden with no neurological function or reduced neurological function for the rest of their lives. So it makes the decision making very tricky, and which is why it's usually a very big multidisciplinary team that makes these decisions together. That's usually then founded upon a very stringent hospital-based or facility-based selection criteria that is usually then followed. And, if discussions are had around that, to include exceptions, but usually that's the way that it will be done.
Wow.
Yeah, it's
But
fascinating.
very extensive. Yeah, I was just gonna say, just a small point there, Malusi. I think they also had like an age cutoff as well, isn't it? To say that, if you're over 65, maybe you might not best benefit. Unfair, but I guess they might not benefit. I wanted us to chat a little bit around the research. I'm not really aware of any randomized studies that are out there. Perhaps if you know of any big studies that are out there, how effective is it? What's the difference? What's the impact of ECMO that they found? Or just any that you'd like to highlight?
Yeah, so the biggest research that started, or the most sort of prominent research when it comes to ECMO is going back to sort of the Caesar trial. That's a really good one to look at, which was followed up by the Eolia trial. So that was looking at outcomes of ECMO in certain patient populations and how it can be utilized and the efficacy of it. There's definitely a huge amount more research available now than what there used to be a couple of years ago. ECMO has really become something that is very vastly researched at the moment in different spheres, whether it's in hospital or whether it's ECPR. ECPR has definitely become a very big talking point, specifically in the research space, to see whether it's feasible, whether it's if it's beneficial to patients, if it improves out of hospital cardiac arrest survival rates. All that kind of stuff is definitely being researched. But at the end of the day, the research that we have to our disposal at the moment is that ECMO, if it's used in the correct ways, is a very, very useful tool, and can definitely improve survival rates significantly if used correctly. So there's a threshold that needs to be kept in mind, that you can't have an ECMO program that has 100% survival rate of patients that go onto ECMO. If you have 100% survival rate of patients that go onto ECMO, you're putting the wrong patients onto ECMO. So it really needs to be reserved for the patients that need it the most, but the patients that can benefit the most from it. And that's where the difficulty comes in, and why nobody is able to come to a consensus about, strict one size fits all selection criteria. And that sort of makes it very difficult to keep that in balance, is the fact that nobody can sort of agree on set selection criteria. But at the end of the day, the data that we have to work with at the moment is that it works. But it only works if you're choosing the right patients and if you are putting them on early enough. So that I would say is quite a big talking point. Is just that ECMO requires a very big mindset shift from what it used to be. ECMO used to be seen as sort of a last ditch effort, a last step rescue therapy that you do, knowing that the patient's going to die anyway. But it's moved very far away from that. So the focus has completely shifted with ECMO to identifying candidates long before they even need the ECMO. So being able to identify a patient that you can see is possibly heading towards a stage where they're going to need ECMO, and planning for it. And if you can implement it early rather than later, it significantly improves the outcomes in those patients if it's implemented a lot earlier rather than later.
Yeah. Last one from my end. I was just gonna add in there that if there's anyone else that possibly is interested in hearing more of ECMO talks, I do know that Queen's Mary do have open talks on ECMO. I think it's on YouTube. It's for free, so you can access it and you can learn a little bit about it. Now, let's move to the next one, Martin. Let me say I am a hospital manager or a director, and I'm hearing all the good things about ECMO, and I want to implement it. What's the team composition like? What team members do I need? What specialities do I need? If I'm looking at hiring a team of ECMO members, or sort of like what's the composition like, or where you're currently working? Who do you have in your team?
Okay, so it's a very big team. So it's not going to be necessarily exactly the same team for every patient. So it's very much similar to a multi-system trauma patient, where you have every specialty involved, or every specialty could possibly be involved in the care of the patient. But at the core of it, you are going to need a team of cannulating physicians, who in South Africa are usually either cardiothoracic surgeons, vascular surgeons, or sometimes general surgeons, but usually cardiothoracic or vascular surgeons are the cannulating physicians. And then sometimes, and then now within the ECPR space, it's now being Emergency physicians are being used, as well as anesthetists can also be trained to do the cannulations. So at the core, you're going to need a cannulating physician. You need someone who can put the patient on ECMO. And then a lot more than that, you're going to need a team of perfusionists or a team of critical care technologists who can look after the machine and look after the physiology and the hemodynamics of the patient regarding the ECMO machine. So you can need someone like that, and usually a team of people that can obviously rotate through looking after that patient, because it's a full-time job of having to, look after the patient on ECMO from a perfusion perspective. And then the biggest sort of difficulty that a lot of hospitals shy away from, or a lot of facilities shy away from, is the burden that it places on nursing staff. So typically what is required for an ECMO patient is you need 2 nurses looking after the patient 24/7, not looking after any other patients in the ICU. And obviously we know what our shortages are in South Africa, and we don't often have 2 nurses to spare to just look after one patient. So a lot of the times facilities, get away with maybe dedicating 1 nurse for every shift to look after only the ECMO patients. But generally you require 2 people. And then everybody else will be involved in the care of the patient, from the physios, the intensivists, anybody from hematology looking after the patient's coagulation picture, their bleeding, all of those kinds of things. So you're using a lot of specialties. So I mean, I could sit here all day and talk about all the different specialties that could be involved in an ECMO patient. It's all of them could possibly be involved depending on what is going on with the patient. So from the ECMO side itself, you need an ECMO specialist who is trained in ECMO, who is able to do the procedure, look after the patient, knowing what the ECMO is doing to the patient and how the ECMO is interacting with the patient. You're going to need a team of perfusionists, and then you are going to need a big group of nursing staff that are able to look after the patient. And then everybody else that sort of comes along afterwards is usually then part of the team to treat the underlying cause of what is going on. So they will be involved in the patient, but not actively involved with the ECMO side of things. So the biggest part of that would then be, the cannulating physician, your perfusionists, your nurses, and then the intensivists that will be looking after the patients, who would also have to be a trained ECMO specialist to then look after the patient in the ICU.
I've not heard you mention the paramedics, but I'm sure they do come in some way there.
No, they definitely do. They definitely do.
If you had to add that, Martin, because you've done the critical care ECMO cases back then, when you transported those patients from one facility to another, what was your role in terms of functioning in that team?
So I think just on what Elias said there, from a hospital perspective, internationally, hospitals have their own dedicated ECMO teams. So they would have a team and their own paramedic that works with them all the time, doing all of their ECMO retrievals with them. Whereas in South Africa, we don't really have paramedics that work for the hospital. So it is you're going to be making use of a service that will then provide you with a vehicle and with paramedics who are then going to assist you with the transfer. So from my perspective, my experience of how I used to sort of integrate into that team is usually we would, the whole process would look something like we would go to the receiving facility. We would pick up all of the equipment, the cannula, the surgical equipment for the cannulation procedure, the ECMO machine, everything that's required to put the patient on ECMO. We would pick up the perfusionist and any of the doctors who would like to go with us, but usually they go on their own. And then we go to the referring facility. And when we get to the referring facility, it depends on what resources you have available. So there have been times where there's an anesthetist available at the referring facility who can sort of be the anaesthetist for the procedure. And sometimes you get there and there is no anaesthetist. If you're there on a Sunday morning at 3:00 and there's no anaesthetist available to assist you with the procedure, then the paramedics role or the ECP's role in that situation would then sort of be to play anaesthetist in a sense, doing the same things that we do with a normal critical care retrieval. We're going to be looking after the patient's ventilation. We're going to be looking after their hemodynamics and their inotropes. We're going to be keeping them sedated and analgesed and paralyzed, and keeping them in whatever state the doctor requests for the procedure itself. And then obviously if there isn't an anaesthetist available, there isn't really so much for you to do during that time. But you would be preparing everything for the moment the patient is on ECMO. So from a critical care paramedic point of view, a lot of what you do on an ECMO retrieval is logistic based. So nobody knows your ambulance like you do. Nobody knows your equipment like you do. And the people that are with you are not trained to work pre-hospitally. And that is where the big difference comes in, or the big challenge comes in, of having to work with those staff who are sort of in charge of the patients, who are not handing the patient over to you, but you are still responsible for transporting the patient safely. So a lot of it comes in with the paramedic being in charge of the logistics, being able to plan how are we going to load the patients, how are we going to package the patient on the stretcher, where are we going to put all the equipment, what drugs are we going to go with, what drugs can't we go with, depending on how many infusion pumps you have available. Most of the time those patients are coming out of ICU on 10 or 12 infusions, and you have to be able to manage all of those different things. And then during the transport itself, it depends what kind of a relationship you have with the perfusionist. So the perfusionist will always go with you in the back of the ambulance to look after the ECMO machine. And obviously, as you grow relationships with these people, you can be more involved with the ECMO side of things, and be involved in any changes that are made to the ECMO machine. But that is not your sole responsibility. Your sole responsibility is looking after all of the medications, making sure that the patient is sedated and analgesed, looking after the inotropes, and just looking after the ventilator. So obviously ventilation becomes very simple once the patient is on ECMO. We come down on every single setting down to rest settings, which is what the patient remains on once they are on ECMO. So the biggest thing that I can say surrounding that is logistics and patient safety. So as the critical care paramedic, you are looking after the safety of the patient with everything that's going on, and all the extra machines, all the extra monitors, everything that is going on with the patient, and all the possibility for complications just because of the fact that they are on ECMO. So you need to be able to set up or package the patient and transport the patient in such a way that you can prevent the catastrophic complications that can occur from occurring, such as decannulation or air in the circuit or whatever the case may be. That is your responsibility to make sure that those things don't happen during transport.
Look, sorry, Malis. I'm getting. Thanks for explaining. You're thorough in terms of explaining, and there's two questions. I know we're running out of time now, and the two questions stem from the fact that you obviously worked in the private ambulance service in Gauteng. For cases of ECPR, when you guys did cardiac arrest, was there any a checklist that existed, obviously for ECPs or paramedics when they resuscitate a patient, to say, okay, this is the checklist, this patient can benefit for ECPR when you transport them to hospital, or that information was not there, or that checklist was not there as yet?
At the moment, or when I used to work in Gauteng, those checklists were not there. We've ECPR as a whole has only recently started in Gauteng. It's not yet obviously pre-hospital. It's only being done in emergency departments for qualifying patients. But it is slowly but surely moving towards a place where pre-hospital staff are being sort of alerted to the fact that ECPR is a possibility for patients. and there is going to slowly but surely start coming sets of criteria to look out for, to be able to help the pre-hospital staff play that role of being able to identify candidates for ECPR, the same way that we do when we go and fetch a patient at an outlying hospital that is intubated, ventilated, and critically ill. The same way, in those situations, we can be the first voice that can advocate for the patient and make sure that the patient is able to go to a facility that is capable of ECMO, if we are able to identify that the patient is possibly an ECMO candidate. So those things are slowly but surely starting to happen, but that can only really come with more training, more exposure to those kinds of patients, and more buy-in from everyone to be able to buy into that system of, everyone playing their role. And in a setting like South Africa, critical care paramedics really do have a unique, role to play when it comes to being that voice of, advocating for the patient in those scenarios, to be able to identify whether they are possibly a candidate or not. And if they are, making sure that you follow the correct procedures to get them going down the correct line of treatment and going to the correct places. And that is going to be the same for the ECPR cases. Pre-hospital staff will slowly but surely start to be trained to identify ECPR candidates pre-hospitally, and then also know which facilities they can take these patients to for ECPR management.
So one of the biggest things that I'm getting from this is that you've said it, is that in so many ways that it emphasizes the importance of interprofessional collaboration, each of us working together, knowing about different types of capabilities or what the doctors can offer, what paramedics can offer. Because ECMO, another thing that comes is that it's a team sport. I mean, when I was at UJ, we were taught to work as a team, and it's important that you're able to function as a team. You might not know these people that you're working with. You might meet them for the first time, but it's important that you find your feet and function as a team. The last question that I have for you is that in terms of HEMS, because I'm a HEMS fan, and ECMO, and I've never seen, maybe it's my naivety, but possibly doing HEMS missions on doing an ECMO transfer. What was your experience in terms of that? Is it feasible, and was it easy functioning in that role? Because I mean, having worked HEMS for the past couple of years, is that there's limited space, there's limited of people that you can take with, and also if you think about that envelope of safety, I'm not sure how heavy is the equipment. Is it HEMS rated to function, to be transporting patients like that? All of that brings complications. I mean, obviously you have that experience having worked in that sector.
I think I was just going to add that does the machine work on batteries, or do I need to plug it in? What sort of electricity do I need? Yeah,
I'll
go on.
get to that. So I can say that during my time in Gauteng, there was literally one transfer of a patient that was on ECMO, and I was lucky enough to be the one to do it. And so it's not something that happens very regularly, where patients are transported whilst on ECMO in HEMS. It used to happen a couple of years ago, but there's been a bit of a move towards rather doing it either, if it's extended distance, doing it on fixed wing, or if it's reachable by a land ambulance, we're going to do it with the ICU bus. But I can definitely say that the one experience that I did have doing a ECMO transfer on HEMS was definitely a very, very big challenge. There's a lot of factors that play into it. So we were lucky enough. We were in a 430 machine, so it's big enough to accommodate, all of the equipment, but there's still not a lot of space. So obviously, depending on the service and what machines they're running, if you're running small machines, you're physically not going to be able to fit the patient into the helicopter. It's just impossible. But if you are lucky enough to have access to some bigger machines, you definitely can do it. But I do remember on the day that I did it, it was almost December. It was very, very hot. the patient with all the equipment was very heavy. And usually when we do an ECMO retrieval, as I said earlier, we have the perfusionist that comes along to look after the ECMO machine. But on that day, it was just too hot to be able to accommodate another person into the helicopter, which meant that it was my partner and I, so two ECPs looking after the patients in the back of the helicopter, with nobody else to help us. So there was a lot of thought that had to go into planning for that transfer. So we transported the patient with a mechanical CPR device already in place, connected, everything was set up. In the event of something occurring during flight where we physically wouldn't have enough hands for someone to be doing chest compressions and for us to be sorting out whatever complication there is to sort out. So there's a lot more planning that has to go into a HEMS mission with ECMO. There's a lot more things that can go wrong. With regards to the machines, all of the machine, there's currently 2 machines that we have access to that are HEMS rated. So that day we obviously did have access to a machine that is rated for flight. And then the machines do have batteries. They can last anywhere from 90 minutes to sort of 2 hours, depending on how fully it was charged and how old the batteries are. And then depending on what kind of vehicle you're in, you can plug them in. But it depends, whether the inverters and the power supply you have are strong enough to be able to supply that kind of machine, which is also another big, sort of consideration that we have. And then together with that, a ECMO machine usually comes along with a heat exchange device, which is there to heat the blood, because obviously we're taking a large amount of blood out of the patient's body, which makes them very, very susceptible to hypothermia, specifically in the neonates and the pediatrics. They go hypothermic very, very quickly due to such a large percentage of their blood volume being outside of their body. And we can't plug those heat exchange devices in the ambulances or in the helicopters, because they obviously have an element and none of the inverters are strong enough. So that becomes a very big challenge for us during a transportation, is looking after a patient's temperature and making sure that they don't go, hypothermic. And so all of those factors sort of come together, and that's what makes ECMO retrievals as difficult and as challenging as what they are, because there is just so much to think about, and so much to plan for, and so much to do. And that's in cases where nothing goes wrong. And, when something goes wrong, it just goes to a completely another level. But yeah, that's what I've got to say on that.
When you say things going wrong, sorry, Malisi, I was just going to say that I'm thinking of a tube dislodging, right? Now think of a cannula dislodging. I'm not sure how, if it's going to be like a dialysis machine where it's just like blood everywhere. So
it's a lot worse than a dialysis machine. So usually for an adult patient, you are flowing anywhere between 3 to 5 liters of blood per minute. So you can imagine if a cannula comes out in 45 seconds, you've bled out half of your blood volume onto the back of the ambulance. So it's definitely a lot worse than a dialysis machine.
Yeah, I was thinking of someone shouting, say, the battery's dead.
You don't want to hear that.
Oh, they'll be catastrophic. That's the end of it. All right. I think we have to round up. This is a lot, very informative. We thank you very much for this information. But
I think I had one more, Malisi.
Oh, yeah. Continue.
Yeah. I guess this is just food for thought, right? Like, I know you work in retrieval mostly, but how long can you keep a patient on ECMO? I know on the ventilator you can keep them for this ever number of days, but is it the same? Or like, how long can you keep a patient on ECMO for, actually?
So it really depends. So there's a difference between a patient that is on VA ECMO versus VV ECMO. So usually the VA ECMO patients respond a lot quicker, and the hearts recover a lot quicker than the lungs. So VA ECMO runs are typically very short, under 2 weeks. technically, usually we try and keep them under 2 weeks. And if we get to that point and the heart is fully recovered, but the lungs haven't, that's the time when we will then convert from a VA circuit to a VV circuit, where we will then stop supporting the heart and only support the lungs. But then for the VV side, it can carry on very, very, very long. During COVID, there were cases that went over a year, almost up to 18 months of patients on ECMO. So it can go very, very long. Typically, they don't go that long. It's a month or two on VV ECMO, and that would sort of be a longer run. But it really depends on the patient. The biggest problem with that is just resources and finances. So technically, a circuit can only be used on a patient for, according to the manufacturer's specifications, can only be used for 28 days until it has to be changed. But every time you change that circuit, it's many, many tens of thousands of rands to replace that circuit. So in South Africa, we really do our very best to preserve our circuits for as long as possible, because medical aids usually only cover 2 circuits per patient. So we really need to draw it out as long as we can and really look after our circuits to prevent having to change them. Obviously, we would need to change them once they start clotting. So once the membrane starts clotting, you're going to need to start looking at changing the circuit. So we do everything to look after the patient's coagulation status and prevent the circuit from clotting. So that also plays into how long patients are able to be on ECMO. But yeah, that's sort of the standard of how long. If the biggest disparity there is obviously VA runs are a lot shorter, less than 2 weeks. And then VV runs are just however long the lungs take to recover. So sometimes lungs can take a few weeks to recover, and sometimes they can take, however many months to recover.
Yeah. One day we'll talk about the socio-economic effects of of patients receiving ECMO.
There's a lot to talk about with that. There's a lot to talk about.
Yeah, there's so much to talk about it. Yeah, I had a lot of questions in relation to the practicality and when it can be applied. But I think because of the time that we permit ourselves to talk about one subject, we might have to pause now and maybe have another episode where we discuss other parts of it. But for a person that is gonna just watch this episode, I want us to talk about a new qualified paramedic who says, I'm interested in this. I'm going to go to this space of critical care and I want to just function in that space. How would you advise them? And then also, is there anything that the HPCSA says about paramedics or ECPs functioning in this space? And then lastly, you've spoken about a body that governs this and that gives guidelines about this. It sounded like it's an international body. Do you want to talk about that too? So it's 3 components. Sorry.
Okay. Yeah. So I think for a new paramedic that's interested in critical care and interested in ECMO, I think the first sort of priority that I would say is getting exposure in critical care. So I think, an ECMO retrieval is sort of the pinnacle of critical care. So it's the most difficult, it's the most challenging, it's the most to think about out of any transfer that you will do on an ICU ambulance. And I think in order to get to the point where you can be comfortable to lead an ECMO retrieval, you need to be very comfortable and competent and, confident in your own critical care abilities. So, and that all just comes from exposure and doing as much training as you possibly can. So, doing aviation for healthcare provider courses, doing airway courses, attending the ECMO courses. So, I'm a member of the ECMO Society of South Africa teaching faculty, and we provide 4 courses a year in Gauteng, where we do an ECMO specialist provider course that paramedics can attend. I attended it myself back when I just started doing ECMO, and that I would say is probably the best route to follow. And then from there, once you've got that training and that exposure and your mind is sort of geared towards ECMO and what it is and how it works, you need to then just get exposure to dealing with it. You need to be hands-on with the machine as often as possible. I know for me, I spent a lot of time in hospital. I tried to make, relationships with doctors that I knew were doing ECMO very regularly, and I would spend time with them in a hospital, looking at the machines, talking about things, getting exposure, just being around ECMO patients. And then, if possible, if someone hears of an ECMO retrieval that is happening and they're interested in going, being able to step out of your comfort zone and just take that step to go with. Even if you're not going to be leading it, but just getting that exposure and getting used to the way things work and getting comfortable with the machine and the dynamics of working with an ECMO patient, I think is the best route to follow. And then from there, it's just continually being, current in the way that you practically apply your skills. ECMO is definitely one of those things where, if you don't use it, you lose it very quickly. And just everything about complication management, being able to manage the complications on the machine is very psychomotor. It's not difficult, but if you haven't done it in a long time, you're going to struggle, especially when the pressure is on to, change a membrane or go onto a hand crank or whatever the case may be. And if someone is deciding to be involved in ECMO, you really need to make that commitment to stay fully committed to it and keep yourself up to date and trained so that when those pressure moments come, that you are able to, deal with them adequately. And then just on your last point about the governing body. So yeah, we have the ELSO is the international governing body. There are multiple different chapters of ELSO. So South Africa falls under SWARC ELSO, which is Southwest Africa and Asia chapter. So we fall together with the rest of Africa, the Middle East, India, and the rest of Asia. And that all then forms part of ELSO, which is the overall governing body, which originated in America. So they sort of have the guidelines written. They have guidelines written on everything from setting up an ECMO program to how to do an ECMO transfer, ECMO transportation, every guidelines on, everything that revolves around ECMO. And then they also then provide training around the world to train people in ECMO and different levels of those courses to become a different level of an ECMO specialist. And then in South Africa, we have a sort of governing body, which is the ECMO Society of South Africa, which is sort of the only body that we have that sort of is a central body for ECMO and ECMO training. And that is sort of how things work here. So the ECMO Society of South Africa then sort of becomes the umbrella for ECMO in South Africa. I think I missed your question on HPCSA. So as far as I know, there's nothing that sort of governs what a ECP is allowed to do when it comes to ECMO. It's pretty much everything within an ECMO retrieval space. You are going to be doing what falls in your scope of practice. So you're not going to be doing the cannulation. You're not going to be, priming the machine. You can be trained to prime the machine, but it's not going to be your job. So from a HPCSA standpoint, there's nothing specific written out regarding ECMO, but you can, as an ECP, be trained to fully function or fully operate the machine, know how to prime it, know how to manage all the complications. And then obviously everything else that goes on with the patient is your responsibility that falls under your scope of practice, whether that's ventilation management, infusions, analgesia, sedation, inotropes, and the rest of the critical care skills that a ECP would be doing on a daily basis.
All right. Martin, thank you very much for coming to the Para podcast. We really appreciate your time and the information that you've shared with us. I've learned a lot on this episode, and I do hope that our viewers globally are going to learn a lot too, and possibly inspire someone to say that they want to be part of such a team. I wish you all the best with your studies, and hope to meet you one day on the road or wherever where we will be. I do invite you for another episode where we'll talk about other matters that are related to this in other finer details as a second time around. Thank you very much, and thank you everyone for watching. Cheers.